Hello and welcome to ECHOMAP, the GP's practical, easy and above all useful ultrasound tool. So today, a typical case from general practice where very clearly ultrasound could have been caught out if Doppler hadn't been used. And that's why you'll see there it's a perfect illustration. When I tell you that every image explored in ultrasound must necessarily have benefited from a Doppler shot, well, here we're going to have exactly the perfect illustration. So first and foremost, if you like this channel, as usual, put me a like, subscribe to the channel. It'll keep you informed when new videos are released. And it also encourages me because it shows me that this extra work I'm doing at the end of my general practice consultation actually serves you and is useful, and that it's not time wasted. Same on Facebook, put a like, subscribe to Facebook. And right now, the Introduction to Ultrasound course is still being offered. The link is in the description. I really encourage you two to join me in this training to try to go further and then learn how to use an ultrasound machine, how it can benefit your practice, because really I can't encourage you enough to bring this great device into your consultations. It does an enormous amount of good for you and your patients. So this is a simple case of a young patient who comes to see me because she's noticed that she has a lump on the back of her skull and it's worrying her. Every now and then it's not as big. Every now and then she feels like she's palpating it a little bit bigger and she'd like to know what it is. It's absolutely painless to palpate and clearly quite firm when touched. In direct contact with the scalp, I thought it was exostosis. I thought it's really firm in the finger. We'll confirm this quickly with the ultrasound machine, and then overall the problem will be solved and the patient will be reassured. And so I attack my high-frequency ultrasound. You recognize it's linear there, and this is what I get. Now I'm thinking, that's not exostosis at all actually. We've got two images, let's describe them a little together. We have two globally anechoic, or at least very strongly hypoechoic, images within the scalp. Here we see the scalp, this somewhat peculiar aspect, just forward here of our bony cortex. And then we have the equivalent of two lesions. Let's explore a little. Ultrasound is always something dynamic. So you can see that yes, it's right next to the skull. It's likely in any case liquidian, and so it completely calls into question my diagnosis of exostosis, since we would have had a deformation of the cortex, and that's absolutely not the case here. As you explore, you notice that you have small areas perhaps here that are echogenic. Inside, so not quite anechoic. I feel like I'm seeing something here too, perhaps something a little linear within anechoic images. And why not the posterior reinforcement here and here? So this calls my diagnosis into question again a bit. I thought maybe leave on a sebaceous cyst in this case, an epidermoid cyst, since inside you can have keratin inclusions that are going to be hyperechoic within a kind of hypoechoic magma usually, possibly why not anechogenic. And then this posterior reinforcement, hard to tell anyway, but this impression of posterior reinforcement leads me to think that it's something really liquid-like. So this posterior strengthening, why do I say hard to tell? Because very clearly it feels like you can see it. Well, we've got the skull here, and the skull is going to be the source, particularly in areas that are really perfectly perpendicular to the probe, of reverberation artifacts related to bone calcifications that will be able to give the impression of seeing a posterior reinforcement here. So be careful when the structures are really close to the bone, because it can still be extremely misleading, and I systematically find that concluding a posterior reinforcement when you're really stuck to the cortex is very risky, and there's a big chance of error. As I told you in the introduction, every image discovered in ultrasound should benefit from a Doppler shot, because Doppler is going to decide a lot of things. Every structure discovered in ultrasound must of course also be measured, as was the case here, since it will enable you to make a note of it in your medical record and assess a subsequent evolution should you need to return to ultrasound. So here we have our two leads. I say leads in quotes, which are around 8 mm and 7 mm, so small size, small lesion in the skull. You can already see that ultrasound has brought us quite a bit, since the clinic oriented towards something bony, and here we're likely to be more on something tissue or fluidic. And we had a clinic referring us to something unique, and finally on ultrasound, we finally have a double lesion. So the Doppler has challenged everything in my thinking, and that's why I tell you that you should never conclude before you've used the Doppler. On Doppler, we actually have a clearly visible signal within this anechogenic zone that appeared liquidian, and here the Doppler calls everything into question, since there's no reason for us to have a Doppler signal within the fluid. We're going to overturn that 100% liquid lesion diagnosis based on Doppler alone. So this is very important to understand. What's our Doppler like? It's pretty well organized, presumably central, and it seems to start from that little echogenic structure we spotted in the first place. Same thing here. At this level, we also have this little hyperechoic structure, which I thought was keratin from an epidermoid cyst, which seems to agree with the Doppler in any case. Let's continue our exploration. You can see here that I've enhanced the image a little, and we really have two very central vascularizations of this lesion, and that obviously makes us think of adenopathy. That's it, we're getting started. So see how we went from a clinic where we had something bony to a first ultrasound that concluded a bit hastily to a liquid cystic lesion, possibly epidermoid, and finally the Doppler, which straightens things out, finally pointing us in the direction of a silly adenopathy, or at least two silly adenopathies. We're going to perform a pulsed Doppler this time to see a little bit. We classically have a visceral type low resistance flow, which is very classic in adenopathies, especially when they're post-reactionary. We're going to perform a microflow Doppler in order to analyze the flow a little better, and notice to what extent we have vascularization of the entire structure, so absolutely not liquid, totally tissue. Here, of course, we see the most important vascularization, the hilum, which will send some branches. And you can see that within the tissue here we have a very weak Doppler signal, which is normal since the vessels are much smaller, but in any case well present, both within this structure, but also within this structure. So you see that in the end, this is a totally tissue lesion, contrary to what the ultrasound suggested at first glance. The second lesion is exactly the same, an adenopathy with a central, well-organized hilum, and then a small overall vascularization of our adenopathy. Here you can see how it looks on a dynamic image. So you really see the point of always concluding your ultrasound with a Doppler shot. It really is essential if you want to progress and avoid diagnostic errors here. So we've obviously got two adenopathies here, both benign adenopathies with a size of less than 1 cm. As we've seen, two oval lesions, a ratio of 1:2 is what's recommended to conclude. In any case, orientate towards a benign adenopathic lesion. Contours that were sharp even, with clearly visible boundaries. A hyperechoic central hilum that we saw very poorly. We guessed a little. That's what led us to think of keratin deposits. In some cases, this central hilum can be difficult to see, and particularly so when it's hard to turn around the lesion. And that was the case here since the patient had braids in her skull, and so I couldn't actually direct my probe exactly the way I wanted to, and so I missed a part of the ultrasound, which is the double grid, a central vascularization that was perfectly visible here both in power Doppler but also in microflow Doppler, a homogeneous hypoechoic ecostructure that can in some cases, and particularly in post-reaction adenopathies, be totally anechoic and perfectly misleading. It can mimic an abscess, it can mimic a cystic lesion. So be careful. When on top of that the clinic gets mixed up and you're not sure, you really need to think about using your Doppler. And absence of calcification or cystic logates, it's going to be a rather hyperechoic adenopathy overall with little anechoic rounds inside. It's more for thyroid, cervical adenopathy, but I wanted to note it here. So there you have it, this case. I hope it interested you and reinforces the idea of always taking a few seconds to put a Doppler shot. And I guarantee that if you do it systematically, there's bound to come a time when you'll change your mind about your diagnosis, as was the case here. See you soon on ECHOMAP. Remember to put a like, to subscribe, same on Facebook, and then do this training because it will make you progress too. See you soon, bye bye.